Hello, my name is Giovanna Venera, and I'm an occupational therapy student doing my second level fieldwork rotation at Banner University. I'm going to be talking to you about ECMo. So, what is ECMO? ECMO stands for extracorporeal membrane oxygenation. It's used in life threatening pulmonary or cardiac failure situations. It's typically an emergency approach after exhausting all other interventions, and it's usually used as a temporary support for only a few hours, but sometimes a patient can be on it for days or months depending on their medical status. ECMO is used in transition to allow for organ recovery or until a patient receives a heart transplant or a more permanent device can be inserted depending on the person's situation. In most patients, the duration support is required for about 1 week. So how does it work? ECMO pumps blood from the patient's body through a cannula to the oxygenator, which adds oxygen and removes carbon dioxide. It essentially works as an artificial lung. It then sends the blood back to the patient via a pump with the same force as the heart. The cannulas are usually heparin or bio-coated to reduce the risk of clot formation. Mechanical ventilation must be continued during ECMO support to try and maintain O2 saturation of blood ejected from the left ventricle to at least 90%. So there's two different types of configurations of ECMO. You'll usually see them written as VA ECMO or VV ECMO. VA is veno-arterial, which is used for cardiogenic shock. So it essentially provides support to the heart and the lungs. So the blood is drained from the venous system and then returned to the arterial system, whereas the veno-venous, the VV ECMO, is used for respiratory failure, most commonly acute respiratory distress syndrome, pneumonia, trauma, or primary graft failure following lung transplantation. This one only provides support to the lungs. So the blood is drained from the venous system and then returned back into the venous system. Typically, about 5 liters of oxygen per minute is supplied to the blood, but sometimes with the VV ECMO, a single access cannula is not enough to achieve the sufficient amount of gas exchange. So an additional access cannula is inserted, which increases the amount of flow to 7 liters of O2 per minute. So for VA ECMO, there are 2 different access points. You have the central and the peripheral. For the central, this one's implemented in the operating room and is a short-term support. So this is pictured in image B. So it's inserted directly into the ascending aorta and the right atrium, whereas the peripheral access can be placed outside the operating room via a surgical cut. So for image A, they access through the femoral artery and then either the femoral or internal jugular vein. So this one is a little bit lower, compared to option C, which is where they insert it to the standard venous access of the internal jugular vein with the arterial return to the subclavian artery. And this just allows for a possibility of the patient to ambulate while on ECMO because it's up out of the way. For VV ECMO, there is only one access point, and it is through the peripheral, which is using both femoral veins. So for outcomes, the success rate is, it has been typically hard to study how well the survival rate is after ECMO, but I found one of the largest published series to date, which looked at 1,000 patients supported on ECMO at the University of Michigan. And out of those 1,000 patients, they found 88% of the 586 cases were success rates for respiratory failure in neonates. They had 70% success rate out of 132 cases of respiratory failure in children, and a 56% rate out of 146 cases of respiratory failure in adults. For the cardiac failure, there was 33% survival rate out of 31 adults with cardiac failure, and 48% of survival rate in 105 pediatric patients with cardiac failure. So kind of as I mentioned before, there still is a lot of research that needs to be done because for the adult cardiac one, they only had 31 adults. So it's kind of hard to get an accurate representation whether that 33% survival rate is truly accurate. So when looking at adults versus pediatrics, nearly 50% of patients treated with ECMO are neonates, and they use it primarily for when they have immature lungs and insufficient surfactant. They did find that risk factors for intraventricular hemorrhage is most clearly present in neonates, and when comparing seizures, they're more present in about 5 to 10% of neonate patients compared to 1 to 2% in adult patients. And they think this increase may be due to this increase in seizures may likely be due to the development vulnerability that children have. I also did find that the majority of ECMO support for neonatal patients is VA cannulation, compared to the majority of adults is VV cannulation. So when looking at the lasting effects, Extracorporeal Life Support Organization collects data internationally on all technologies used to support cardiopulmonary function. So they typically document on acute neurological complications such as seizures, infarction, hemorrhage, or brain death. And that's why I was able to compare the pediatrics versus adults on the slide before, but they still lack a lot of information for functional outcomes and disabilities. I did find a recent study evaluating the quality of life and adaptive behavior following admission in the PICU in pediatric patients, and they found that prolonged ECMO was one factor that was associated with reduced quality of life. But there still is a lot of limited information obtained from those long-term impacts of ECMO, especially on development, school performance, and quality of life, and it needs to be further studied. It's also important to note that it is difficult to determine these lasting effects due to the complexity of ECMO, because complications can occur either prior to the initiation of ECMO, during or after the decannulation. And during this time, neurological examinations are rarely performed just due to the patient's condition of being sedated, intubated, and possibly paralyzed. So it's really hard to actually see when these effects are becoming apparent. There is also noted a wide range of neurologic complications that can occur, and most of them include the intracerebral hemorrhage and ischemic stroke. They did find that 9 out of 10 autopsies reports indicate these complications after a patient died after being on ECMO. I did find one article that was produced in 2019, so pretty recent, and it did look at the quality of life and lung function in survivors of ECMO compared to people who were just on a mechanical ventilator, and they were able to follow them 1 year after discharge from the ICU. So there was 84 participants, 34 of them received VV ECMO, and 50 of them did not. They actually found a year later that the survival rate, there was no difference between ECMO and conventional mechanical ventilation. 65% survived after ECMO and 56% survived on the conventional ventilation. Both of them, the most common cause of death was due to multi-organ failure. Respiratory function tests and lung imaging, they followed them through to the end after that year, and they did show that almost all of them had a complete recovery between both groups. It was noted, though, that non-ECMO patients reported that they had a greater impairment of quality of life. And it was noted in the article that one of their limitations was that many of those patients had more comorbidities than the patients that were treated with ECMO. And they did find that the hospital length and the mechanical ventilation length were almost doubled in ECMO patients. Non-ECMO patients reported more fatigue, weakness, limitation in ADLs, and hardship in return to previous life, and many of them even experienced PTSD. In contrary to other studies, ECMO patients did not report experiencing an impact in quality of life after discharge, and they do hypothesize that this was maybe related due to the particular care that ECMO patients receive from medical, psychological, and there's just a lot more resources available compared to those who received standard treatments. ECMO patients also did not have as many comorbidities, which I had mentioned, so these could impact the numbers and their success rate. So when looking at rehabilitation, kind of the most important takeaway from this whole thing is what can we do with them? In recent development, studies have looked at patients who receive active OT and PT while on VV ECMO support specifically, and they did note that patients recover more quickly once taken off ECMO. Patients are encouraged to exercise and stay mobile, even advancing to ambulating while on ECMO. Unfortunately, Banner does not have ECMO machines, though, that allow for ambulation. But we can focus on addressing strengthening, coordination, cognition, and communication. It is important to note, though, that not all patients are appropriate for rehabilitation. And some of these include hemodynamically unstable, deeply sedated, or if they're receiving a neuromuscular blockade. More studies need to be done to define the barriers of active therapy. I did not find any specific limitations with like arms or lower extremities when ambulating or moving with the cannulas. So how to mobilize. It's important to avoid kinking and dislodgement of the cannulas. If this were to possibly happen with VV ECMO, it can lead to immediate desaturation. And if this were to happen with the VA ECMO, it can cause a sudden drop in blood pressure and cardiac output. So we really want to make sure that the cannulas are secured with sutures to prevent tugging, twisting, or pulling on them anytime throughout this mobilization. Typically, they'll secure the cannulas to the patient's head with elastic tape, crepe tape, or indwelling catheter leg strap. And as in this picture here, they've kind of put it out of the way over her head. So you want to keep it out of the way. So you want to just make sure you know where those cannulas are at all times. And placement of those cannulas can affect mobilization, so they will have a lot more limited mobility if they're in their femoral veins. So when do we mobilize? So for low risk, I had found that typically these patients, you will most likely be able to work with them while they're on ECMO is if a patient has an endotracheal tube or tracheostomy, if their oxygen saturation is above 90%, their respiratory rate is below 30, their mean arterial pressure is within the target range, and they're able to follow commands. For potential risk, you want to be cautious before you mobilize them, is if they're having ventilator dysynchrony, high frequency oscillating ventilation mode, if they have pulmonary hypertension, if they've had a craniotomy or an acute spinal cord injury. Specifically for high risk ones that you do not want to mobilize a patient on is if they're on blood pressure on IV, cardiac ischemia, raised intracranial pressure, uncontrolled seizures, or an intra-aortic balloon pump. So the team roles. So typically when you're going to mobilize a patient, there's going to be a lot of team members that are included in this to make sure that it's, happening safely. So you'll have the ECMO specialist present to manage all of the aspects of the ECMO. You'll have a bedside nurse to manage all of the lines and monitoring the vital signs. And then you'll have the PT and OT lead the therapy session and a respiratory therapist to manage the ventilator. But typically, if all of these people are present in the room, it's more likely to have a safer outcome. So here's my resources. So overall, ECMO can be beneficial for saving someone's life, and earlier therapy interventions can have a major impact on their overall recovery. Thank you.